So when thinking about traumatic brain injury, or you'll hear me refer to it as TBI, think about the types of impact. So deceleration versus acceleration. Deceleration is when your brain hits or butts up against the side of the skull, like in a car accident, like whiplash. Acceleration is when your brain is hit by something forcefully. Think of violent crimes or assaults. Types of injury: there's primary injury and there's secondary injury. In primary injury, the damage occurs at the time of the injury. Secondary injury, the damage occurs after the injury, because that is related to cellular response from trauma, which is where you would categorize Cushing's triad actually as secondary injury and not primary injury. So in primary injury, there's open head injury and closed head injury. In open head injury, there are different types of fractures. There's linear, depressed, comminuted, and open, obviously, which an open head injury and a closed head injury is exactly the way it sounds. Open head injuries is when the object breaks through the skull, where a closed head injury is when there's trauma that causes bleeding or swelling, but the skull doesn't break and the dura is not torn. The linear fraction that I talked about just a moment ago in an open head injury is a fracture in a line. It's simple and it's clean. A depressed fracture is when the skull is actually pressed inwards into the brain tissue. Comminuted, there's bone fragmentation, and an open fracture, the scalp is lacerated, obviously, and then there's an actual opening into the brain. So surgery is needed to repair the bone fragments in this type of fracture. Closed head injury, different types: concussion, contusion, laceration. There's different classifications of TBI: mild, moderate, severe. Mild, you're going to see a GCS of 13 to 15, moderate GCS 9 to 12, severe GCS 3 to 8. And the basilar skull fracture, that happens obviously at the base of the skull, and it can result in a cerebrospinal fluid leakage. Fluid can actually leak from the nose or ears. Don't stop it from draining if you see it. If you're ever working in the emergency department setting, let it come out. A really quick way to determine whether or not that's cerebrospinal fluid is if you take their white sheet and just hold it up to the fluid, and if it leaves a yellow halo, then you know it's spinal fluid. Clinical manifestations of TBI: amnesia, seizure, altered level of consciousness, disorientation, confusion, bruising, obviously, personality changes, double vision, gait changes. Severe manifestations that you'll see later will be pupil changes, bradycardia, papilledema, high blood pressure, widening pulse pressures, hypotension and tachycardia, which is an indication of hypovolemic shock, nuchal rigidity. Now, if you have a patient coming in with a suspected TBI, don't ask them to touch their chin to their chest. Put a C-collar on them. So they will have nuchal rigidity, just don't do like a meningitis test, ask them to touch their chin to their chest. Assessment data: assess everything. Assess neurostatus, obviously, cardiovascular, so put them on a heart monitor. It's just everything. Treatment: for your TBIs, you want to monitor their ABCs, treat airway, breathing, circulation. Those are your priorities. Continuous vital signs: you want to be able to detect increased ICP if it should present itself. Your patients with severe TBIs will be intubated, sedated, restrained. Suction those patients. Be sure you provide chest physiotherapy when they are recovering. Monitor hemodynamic status. Nursing intervention I included was calm environment for the patient. You don't want to overstimulate the patient, and also that's going to be very helpful for patient family.